All right, I think we're going to start now. So once again, welcome to our Careers in STEM seminar hosted by CSTEM. If you just logged in, my name is Delia.
And my name is Annika. So for
I'm
those
Nathan Mascaro.
So for those of you who are new here, and as a reminder to those who aren't, CSTEM is a nonprofit student-led STEM outreach organization. We aim to connect the classroom curriculum to real-life careers by introducing you to the various professions in the STEM field. We hope to encourage many or all of you to pursue careers in STEM.
So during this seminar, we have invited a very accomplished professional in psychology, and we hope that we will start with a short presentation and continue with a Q&A. So through the presentation, we hope you will learn more about Dr. Mascaro's job responsibilities, educational background, and receive some useful advice you may take with you on your pursuit of similar STEM careers. If you missed the seminar or part of it, it will be recorded and available on our YouTube channel. So stay tuned for that update on our Instagram, or fill out the link in the chat to join our emailing list.
So Dr. Mascaro is a clinical psychologist licensed in Georgia since 2007 when he completed his postdoctoral fellowship at Emory University. Prior to this, he received his PhD in clinical psychology from Texas A&M University and his undergraduate degree in psychology and philosophy from Louisiana State University. Having spent over 14 years with the Atlanta VA Health System's Trauma Recovery Program, he currently works for a local psychotherapy practice, Atlanta CBT, where he provides treatment to adults experiencing post-traumatic reactions such as PTSD and frequently co-occurring conditions like meaninglessness, insomnia, depression, panic disorder, OCD, addiction, and generalized anxiety disorder. His research has focused on trauma recovery and the human experience of existential meaning. Dr. Mascaro also provides supervision to psychologists and psychiatrists in training for Emory School of Medicine's Department of Psychiatry and Behavioral Science, where he is an adjunct professor. Let us welcome Dr. Mascaro.
Hey, thanks for that. It's nice to be here. Just to let you guys know what what the plan is. I'm going to talk a little bit about what I do as a clinical psychologist. And I'm going to talk a little bit about that clinical psychology, the most about that, but I'll also talk about some of the other forms of psychology. Assuming people are interested in those other types, there's these things, developmental and cognitive and social psychology, industrial organization psychology. So talk about some of the other forms of psychology, but then also I do want to give a little bit of information on some adjacent fields that people often think of clinical psychology sort of in relation to. People are often asked, are you a psychologist or a psychiatrist? So we'll talk a little bit about psychiatry and the difference between the clinical psychologist and the psychiatrist, and also a little bit about another adjacent field, social work. Social workers actually have a lot of overlap with psychologists and psychiatrists, so we'll kind of distinguish those fields a little bit. We talk a little bit about some of the main roles that clinical psychologists can fulfill, the ones I do. We'll talk a little bit about the education and training that's required to become a clinical psychologist, and a little bit less so about becoming a psychiatrist or a social worker. And then we'll open it up for any questions. And so we'll have some Q&A time. But me, I'm a clinical psychologist. I've spent most of my career working at the Veterans Affairs Hospital here in Atlanta in their PTSD clinic, post-traumatic stress disorders clinic. And so I've spent the majority of my time doing assessment and therapy with people suffering from anxiety disorders, particularly the anxiety disorder of post-traumatic stress disorder. A lot of what initially kind of looks like PTSD actually is or is kind of co-occurring with a lot of other things. So I've done a lot of treating of other things that often come along for the ride with PTSD, like addiction and depression and other anxiety conditions like OCD and the things that Annika mentioned. In terms of kind of the percentage of my work, for the longest time, I did a lot of clinical work, like therapy and assessment with patients dealing with things. During that time, I did a decent amount of research as well. So one thing about a clinical psychologist is in your training, you need to have a PhD in psychology. And our training, it is a PhD, so it really emphasizes research and understanding research. So you got to have a good grasp of the scientific method so that you can produce research and also that you can consume it, interpret it, and allow that interpretation of research to inform your practice of psychology. And so at the VA, I did a decent amount of research on treatments for post-traumatic stress disorder and assessment of post-traumatic stress disorder. And over time, I backed out of that and sort of increased the clinical, the amount of clinical time. If we talk about what a clinical psychologist is often doing, people are probably going to think of three main roles, and that's teaching, research, and practice. And someone who becomes a clinical psychologist could spend, kind of mix and match how much you research, how much you teach, and how much you practice. A lot of people are like professors or faculty members at universities where they're mostly producing research and teaching people about psychology. Some of those faculty members also do a little bit of clinical work, and they might have a small private practice, or a lot of people in Atlanta actually, for instance, might work at say Emory, training students and teaching psychology, but they also might have a small position at the VA, or they might have a position in the community in private practice. But generally, if you're a faculty member, research and teaching are going to be emphasized. And so clinical psychology is really the branch of psychology that people think of when they think of a patient sitting in a consulting office, talking about their problems, talking about some distress that they're dealing with, getting some consultation from the therapist on how to overcome or deal with that distress. So that would be the field of clinical psychology. And those are really the psychologists who are actually getting licensed. They have to be licensed in a particular state and eligible to practice psychotherapy. But most of psychology is probably made of a lot of other branches of psychology. And so there are other fields like social psychology, developmental psychology, cognitive psychology, and industrial organizational psychology. And so developmental psychology would just be, if we're thinking of psychology as the study of human cognition, emotion, and behavior, developmental psychology is how those things develop over the lifespan, starting from infancy through childhood and adolescence and adulthood and old age, looking at some of the normative changes that can happen over time. And so most of your developmental psychologists are going to be employed in a university doing a lot of research. Social psychology looks at social forces and how those impact our psychology, our behavior, and affect, emotions, and thought processes. And so looking at various forces, like a social psychologist might do a lot of research on, say, hazing and the impact of these sort of hazing things that happen a lot in college and high school, and noticing how certain behavior of other people or the environment towards an individual might influence that individual's psychology. Cognitive psychology is going to focus more on thought processes, how we make judgments, the various biases, expectations, and assumptions, and how those influence how we feel and some of the behaviors we find ourselves engaging in. And again, developmental, social, cognitive are more your very researchy branches of psychology where you're most likely to be employed in an educational setting. Then I talked a little bit about clinical psychology. Industrial organizational psychologists are the ones that make the most money. They're the ones that study the interaction between psychology and industry and businesses. And so they're looking at, say, the interaction between personality factors and motivation, and how different personality factors match with certain job roles or job skills. They're looking at motivation and what are some of the say environmental forces in a company that might influence an employee's motivation. They're the ones that research hiring. Is, you know, what factors in your hiring process are going to influence obtaining people who stick around and do a good job. So those were the ones in grad school who could never make it through grad school because businesses were trying to snatch them out of the program before they even finished their education. And so interesting field there. I chose the field of clinical psychology because I like the process. I really love the process of doing therapy and interacting with people in that type of setting. I like the helping role. And so I think a lot of people are interested in fields that help people. Some of my main roles as a clinical psychologist are doing therapy and assessment. There's supervision and training of other clinicians. So like I'm affiliated with Emory and help them train their psychologists and psychiatrists. And as I mentioned, I've done a little bit of research. And so that's definitely another option, clinical research. We can answer questions later about that if you're curious about any of the clinical work. But I do want to give you a sense of like what the training involves for a clinical psychologist. And incidentally, if there is something you have a kind of an urgent question on, feel free to ask. But clinical psychology, you have to be a clinical psychologist. You have to have a PhD in psychology, and you have to be trained specifically in the clinical aspect of the field. So that's you get your BS or your BA. It probably is important to get I think with psychology, they tend to be bachelor of BS degrees. That's going to give you a lot of the prerequisites and just a lot of the information that you'll need to get into a PhD program in psychology. And then PhD programs, they're pretty selective. You want to get good GRE scores, so that is important. It's important to have decent grades and pretty good GRE scores. It's comparable to medical school. Most PhD programs are going to last about 5 years. They're all set up to be completed in 4 years. However, because of the amount of research involvement that they're wanting you to do, most people take about 5 years to finish the classes and the training in therapy and assessment that's required for that. In a PhD program in clinical psychology, you're taking classes and learning about psychopathology and therapy and assessment testing. You're also generally working in a training clinic. So like there's a university clinic. So like if you go to and get therapy in the Emory clinic, at the university clinic, a lot of your therapists could be someone in Emory's clinical psychology program who's in training. So that's part of your training in a PhD program in psychology. And you're probably going to be helping out with teaching a little bit, and like as a graduate assistant, and you'll be doing research. Most PhD programs, if you get in, most of your way will be paid. So they'll cover most of your tuition, if not all of it. They should. and they tend to give you a stipend for the work you're doing teaching classes and doing research. It's very different from medical school, where you're pretty much expected to go into debt, and they don't tend to cover tuition and give you a stipend like that. And so a graduate program, now because of that, they have to be kind of selective. And so most clinical psych programs are going to take like 5 to 10 students each year. So as people are applying, you're applying to a bunch of different places. Once you finish the scholastic part of a PhD program to get into clinical psychology, then there's a 1-year internship where you're not taking classes anymore, and you're actually spending an entire year at some location doing a lot of clinical work. It might be a hospital. I did mine for Emory at mostly at Grady, spent most of my time at Grady Hospital, doing work in their sort of inpatient ward on the 13th floor, and a little bit of outpatient work at some of the adjacent buildings. But it's a 1-year internship, all practical work, getting used to a very different environment in which you did your graduate training. And then after that 1-year internship, only then are you allowed to receive your PhD in clinical psychology. After that, there's a 1-year postdoctoral fellowship that you take for a year, getting another year of training before you're allowed to get licensed. And then after that year, you get licensed in a particular state, and then you're basically unleashed on the public without any supervision, and you can do your thing, get into teaching or research or kind of hang up a tile. Just for my purposes, when I was getting started, I did a little bit of everything. So just to say, you don't have to know exactly what you want to do even after your postdoc. I worked part-time at the VA researching treatments for PTSD. I worked part-time at Georgia State teaching classes, and I had a small private practice. And things just evolved, and I fell in love with certain things and fell out of love with other things. And so I started doing a ton of work at the VA. I really liked working with that population, and I liked the gains we were able to get, helping people get better, and spent most of my career so far doing that, until recently when I've started doing a lot more private practice work. And I've actually, I haven't, for almost a year now, haven't worked at the VA, and I'm just at this Atlanta CBT, stands for Cognitive Behavioral Therapy. A lot of therapy I'm doing, a lot of diagnosing people with things and kind of conceptualizing their case to figure out what are some of the environmental and even internal processes that are impacting the distress that they come to me saying they're having, and coming up with treatment plans and therapy to help that distress get better. That's most of what I do. There are other fields that are very similar, that I think definitely in movies, for instance, definitely psychiatry, that sort of get portrayed as doing a lot of that therapeutic work. So I'll talk a little bit about psychiatrists, and probably the most important thing I'll let you know is psychiatrists are not doing a lot of therapy. And so if you want to do the therapy stuff, it's probably you want to become a psychologist or a social worker or a licensed counselor. Psychiatrists are usually spending about 15 minutes with people, talking about symptoms they may be having, and tweaking medications for to help deal with those symptoms. And so a psychiatrist, in distinction from a psychologist, is going to medical school. So they're applying to medical school after undergraduate. They're doing really different prerequisites. They're doing all the, organic chemistry and zoology and probably anatomy, and very different sort of way more biologically focused than the undergraduate degree you'd get in psychology. And they're going to medical school. Medical school's good at making it pretty structured across the country. So it will last 4 years. Once you're done with that 4 years in medical school, then technically you're a doctor and you're an MD, but they're not really going to unleash you on the public until you go through a pretty extensive residency program. And so after medical school, as you're wrapping up those 4 years of medical school, you're figuring out what you're going to specialize in. You could, it might be some form of surgery, it might be oncology, it might be endocrinology, or it might be psychiatry. And if you want to be a psychiatrist, then you're wanting to apply to residencies in psychiatry. And typically the psychiatry residency is 4 years long. And so you're applying to that residency, which could be in the same place you went to medical school, but most folks do try to go elsewhere, and then get 4 years of training, getting exposed to different aspects of mental health, some inpatient, like a psychiatry ward work, some more outpatient, maybe slightly higher functioning work, a little work with kids, a little work with adults, some urgent care / emergency care type settings, tending to be very biologically focused and medication focused. And then after those 4 years of residency, then the psychiatrist can really practice independently. And the psychiatrist could get board certified in psychiatry, sort of another sort of level of demonstration of qualification. And sometimes psychiatrists do a postdoctoral fellowship after their residency for another year of training. So whether it's psychiatry or psychology, you do want to like the field if you want to get into it, because it's a lot of training. If you want a little quicker entry into the therapy world, you might get a degree in social work. And so a social worker might get a degree in psychology, or biology or sociology or whatever. They would go to grad school to a 2-year master's degree program and get an MSW in social work. And so it's 2 years of training. It's a lot less research focused than a psychology degree. And I will say a psychiatry degree in medical school is a lot less research focused. It's more practically, biologically focused, but not necessarily on the research. And depending on whether you want to get into research, you could get a little more training in that in your residency program for psychiatry. But social work is more practically oriented, and it's more emphasis. A social worker will receive a little bit of training in therapy. They'll get a little bit of introduction to the mental health world, a lot more focus on social resources that impact our functioning. And so you're talking about dealing with homelessness, you're talking about dealing with kids needing protection, and dealing with abusive situations. A lot of work also with the elderly who need certain services. A social worker has to be really good at knowing the whole world. And so they need to know the different aspects of medicine, as well as different aspects of social services, so that when they do see somebody suffering from something, it could be homelessness, it could be hunger, it could be some sort of mental health issue that's resulting either from a medical problem or from a need issue, and they need to know the resources to link that person with. And so it's those social workers are doing a lot of work on medical floors. And so when patients come in and they may not have a great housing situation that has something to do with maybe while they're being put into the psych unit, once they're stable on medication, then it's up to the social worker to kind of say, how do we get this person in a stable situation so that they don't keep losing touch with their medications and getting stressed out and kind of decompensating and winding up back in the hospital. And so those social workers do get licensed and they're able to practice psychotherapy, but insofar as their training involves a lot of other stuff, they usually have to seek additional training after they're licensed in order to get a little more understanding of doing different forms of psychotherapy. And insofar as they don't have as much research training, they're a little just less inclined to kind of soak up some of the latest research. And so they'll often need to may either get a little research training or dealing with how to interpret literature so that they can maybe help allow that information to keep their psychotherapy practice up to date. So that's a real cursory overview of probably two of the most adjacent fields to clinical psychology, psychiatry, and social work. And then the other adjacent fields tend to be developmental psychology, social and cognitive, and industrial organizational psychology. Any other major things? I will say one of the factors that distinguishes psychologists from those other professions. Psychologists are trained a lot in testing and assessment and a lot of statistical training. And so we do get a lot of experience interpreting research, producing it, but also administering tests like IQ tests, intelligence tests, different cognitive tests that are good at kind of tapping into like whether or not somebody has ADHD, kind of helping distinguish between the difference between maybe ADHD versus maybe some schizophrenia that's emerging. And so that's a unique thing that social workers and psychiatrists don't tend to do. I like psychology because it helps me help people. I like it because it has a decent balance. I'm not super great at math. I'm not super great at analysis and reasoning, or in terms of not the most eloquent speaker or writer. Psychology, you do need to have some of all of that, though. And so it does demand a balance of kind of the ability to think in numbers, but also in words and also in feelings, and kind of have some kind of rapport, interpersonal rapport with people. And so I like that it allows, it can take advantage of my tendency to not be great at really anything in particular, but kind of a jack of all trades, so to speak. I like that about it. And I do like its emphasis on science and research, the STEM aspect of it. Early therapy was based on some of these Freudian ideas that actually never really got tested scientifically. And that kind of worked their way into the mass understanding of what therapy is, and sitting on a couch for years and years, paying people lots of money to talk about, your potty training and breast and nursing. And that was not, those things were not really based on science or the practice or the science of psychology. And it was only way later in like really the 60s when we actually started doing research on what actually works, when psychologists started researching what actually works to help people get better from some of these conditions, that the field of therapy actually started improving and getting to a point where it actually helped people get better from things. So that's what I like about the fact that it is backed, it's evidence-based, and we're required to be evidence-based, and we're required to do things that are the most likely to help people get past, improve their conditions. So that's what I like. And so that's how the STEM aspect of psychology, I think, makes it an appealing field, at least to me. And I will get this. Well, no, I said that. That's my main advice. Yeah, my main advice is if that's a sort of field that you're into, I think balance is the name of the game. You want it to be appealing enough to read some regular literature, as well as some colder, more quantitative literature. And yet you don't want to have the identity as like just a humanist who's only into feelings, who's not going to get into math at all. You gotta have a little bit of interest and adeptness at the quantitative aspect of things as well. Yeah, so I think I've gone on long enough. Any of those areas, and I will say this is a real cursory overview of this stuff. If you have questions after this, then I put my email addresses up there. And so if you do have questions, feel free to ask later or now. But we have a question from an LA Lakers forward already, I see on the chat. How are tech and AI integrated or getting integrated into the process? I think tech, AI so far is not doing much. The way technology is getting integrated is in linking people with people. I think the fantasies, which may and really hopefully maybe kind of bear some fruit, are that like, an individual could interface more with a program that would ask the right questions and help them get to the right strategies or interventions that would help them, say, treat a depressive disorder. That's not really happening, but I'll tell you how it is happening. More than that, there are a lot of, what would you call, services, kind of web-based services that are linking, especially in psychology, since in psychology there's this law called SciPact that allows psychologists in one state to practice across state lines and treat people from other states with various conditions. And so there are these websites, these programs like Headway is one of them, that a patient or a person can sign up for this service and say, here's what I'm dealing with, and here are my insurance here's the insurance I have. And that service will find a bunch of different therapists that take that insurance and that help treat that condition. So that's one thing. So the way it used to be is like, you might just, if you had an insurance, you would look up all the providers in your area that were actually linked to that particular insurance. And it's a very painstaking process. Now, more and more, there are just these quick searches that can link you right away with someone that treats what you're dealing with and that accepts your insurance. The other way in which tech is being incorporated is apps. Apps are great. Now a good therapist needs to know what are some apps that are going to help your patients. Either, I mean, there are some, like definitely with insomnia. I often tell people you may not need to meet with me if you just download this one app called CBTI, Cognitive Behavioral Therapy for Insomnia, that the VA created, and it's totally free. A lot of people can just download that app, read over the treatment for different forms of insomnia, start doing some of the exercises. It has a good little algorithm that you can input, like when you go to bed, when you tend to wake up, or when you're waking up each day, and it'll see how much sleep you're getting or not getting, and it'll advise you based on an algorithm when you should be going to bed, when you should be waiting up. That's going to make it most likely for you to get the best sleep. And so the AI stuff isn't there, but the tech stuff, there are a lot of really good apps that again are going to help people a lot and are helping people a lot, and a psychologist needs to get familiar with. So I'd say apps and websites that link people with professionals. How did your experience working in the VA differ from private practice work? So the lowdown on that, the VA, definitely, I was in the PTSD clinic. So there was clearly a lot more combat trauma that I dealt with at the VA and in private practice than in private practice. There's always a story kind of behind the big story, though. And working in a government service or any like big hospital, big institution, there's always going to be dynamics that happen because it's a very big institution that often has very big hammers that can't operate subtly. So for political reasons and resource reasons, like PTSD is a very big thing. It's a pretty sexy disorder that a lot of people even seem to want to have. And so like our clinic, for instance, would get we have plenty of resources, plenty of staff, plenty of funding. And eventually veterans realize that's the clinic that has all the funding and all the resources. So tons of people coming into our clinic really faking PTSD, partly because, well, they don't exactly have PTSD, they have panic disorder or depression disorder, but the VA is not really well resourced enough to have, say, a mood disorders clinic that does a good job of treating mood disorders. Or somebody is just like, they don't want to lose their marriage and they're having marital difficulties, but there's nowhere to get treatment for that. And so they kind of say, well, it's my PTSD. I've got this PTSD thing. But then once they link in, say with me, we're ending up doing a lot of interpersonal relationship focused work. So the thing about the VA, and again, any institution that a person might end up working in, there's just going to be an evolution where people are going to be drawn to where the resources are. And so we learned in that clinic, so that clinic ended up looking a lot like a private practice clinic, because it was the only clinic with a ton of therapists and a ton of resources that could treat all kinds of different things. So you're doing this weird thing where on the surface, you're treating PTSD, but sort of under the table, you're treating a bunch of different things. So the main difference was not as much the different conditions, but in the VA, I have to pretend to treat this condition while under the table, I'm treating some very different things. So that was a useful skill to learn. And then at the VA, there's the extra weirdness of there's a whole disability system where people are, if they can prove they have PTSD and they're disabled from it, then they get a significant stipend for the rest of their lives. So we did run into a lot of people just kind of malingering PTSD so that they could get some of the money for it, which is an extra wrinkle that, again, is kind of fun to deal with because it just makes it a little interesting. And especially doing therapy with someone who's faking PTSD to get on disability, but most of these folks have real other conditions that don't really get a disability pay the way PTSD does. So you're kind of trying to just deflect all the fake PTSD stuff while getting at the real condition. People tend to leave the VA because of that sort of dynamic, because nothing really is ever done about it. And so just private practice works a lot more straightforward because people don't have to feign any sort of symptoms. So that's a whole big thing. That's most of my work was very rewarding and very direct, but that is a very substantial portion of the work that anybody at the VA is going to have to deal with. Let's see. What led you to work in PTSD? Yeah, so really what got me started in PTSD was researching it at first. So when I was just kind of putting my toes, so the question is what led me to get involved in PTSD? At first, I was, like I said, doing a little teaching, a little kind of broad-based clinical work, a little bit of everything. And I just started doing research at the VA, mostly to just make a living. And there was a principal investigator named David Reedy who had developed this over years and years, this group-based therapy for PTSD. And so he just needed someone to help him run statistics and sort of manage this randomized controlled trial for this form of therapy that he developed. So I got on to deal with that. I helped organize a lot of the things, and I was one of the therapists actually in the control condition. And unfortunately, the control condition patients actually got just as good as the experimental condition patients, which was not exactly what you want for the study, but everybody got a lot better. And it sort of, it made me realize in some of the people at the VA that I had a decent rapport with some of these people that we were working with. And so I had good rapport with them. My patients tended to get better a lot really quickly. So it really was just helping out with that research just gave me contact with a form of therapy and with a patient population and with a certain type of condition that I fell in love with, and just got more and more interested in it and involved with it. Trauma, this is too big, kind of too long to get into too much in this venue, but trauma, the idea of having an extreme event bias your interpretation of other events. So such that, like, you're living your life and then something happens that you didn't really, either you didn't think it actually happened or you never thought it would happen to you, and suddenly your world gets turned upside down. And now that the world feels more dangerous, or now that you don't trust others or yourself as much as you used to or as much as you thought you should, things start feeling very different. And then as a therapist, your job is to do a little bit of work looking at the trauma and connecting. Well, it makes sense if you went through that, of how you'd be feeling the way you are now and have some of the biases you have now and some of the assumptions you have now. But more of the work is, what are the biases you have now? What are some of the habits you've developed in response to this extreme event that don't actually fit with your current setting or your current world in a way that has you just burning so much energy unnecessarily? That work is such a great template for most mental health conditions. So again, with depression, based on stuff people have been through, they start making assumptions that the world is not a particularly decent place, or that they're not a particularly competent person, or that they're not really a person who really deserves much affection. That's a hell of a bias. It does come from somewhere, and then you can look at where it comes from and look at how those biases show up in somebody's everyday life, and start to notice how they're a little bit off, and how there are ways to looking at the world or oneself a little differently, some ways of taking risks and risking treating the world or oneself a little differently. And whether it's OCD, panic disorder, all those have some version of that, of like, something goes on. Sometimes it's an experience, sometimes it's a little bit of wiring to bias the way we look at the world or the way we look at ourselves. And when you start to notice those biases and not replace them with hunky-dory, everything's for the best all the time, but realistic views of oneself and the world that have realistic mixes of just really shitty stuff, but also really wonderful stuff, you end up making tons of progress when it comes to PTSD treatment or other anxiety disorders, or depression treatment, or definitely addiction and things like that. So yeah, so again, the long-winded, but it happened by accident, sort of. I did it to make a living, got into PTSD, but really fell in love with it. And I think what I like the most is trauma treatment gives you a good template for treating a lot of other conditions that I've found has come in handy. Let's see what led you. And so those are the questions that I'm seeing so far, which is plenty. Did anybody have any other question?
Okay, so I think we're going to, I think we saw another question.
What's your process when working with a patient? Ooh, that's a fun one. So I like to, so there are things that are kind of unique to me, but then there are processes that really any decent practitioner is going to do. So generally, I do want a really thorough assessment. And so I'm going to talk to someone, just get a sense of, hey, why are you here in my office? What's going on? What are some of the main patterns you find yourself stuck in that you want to change? And so get a good sense of what the chief complaint is. And then there are certain domains that we tend to go through that are often relevant, sometimes not, but often are. Just getting a sense of what's the history of the problem, what is their sort of educational background, their family background, what's the person's work background, kind of what's their interpersonal social background in terms of friends and and loved ones, and how those people come and go on, and definitely what are the person's goals. And so it's kind of a broad-based interview. And then I like to kind of see what they say just in work, kind of open dialogue through this interview, and kind of triangulate it with a little bit of quantitative assessment. So there are a couple measures that I like to give people that get at some of the more common depression and anxiety symptoms that people will have. And so I give them this particular measure called the depression, anxiety, stress scales, where there's about 21 different depression questions that help us get basically a measure of how depressed they are. It's the same number of kind of panic, physiological arousal type of anxiety items to help us get a sense of how panic type physiologically anxious they are, and then some more in your head worry type anxiety questions to get us a quantitative gauge of how much of that form of anxiety that they're experiencing, and kind of see how those things interact with what they talk about in an initial interview. And then these days, when it comes to actually treating someone, a lot of the forms of treatment, or the protocols that have been researched to treat panic disorder or an OCD, obsessive compulsive disorder, or PTSD, those are usually about 8 to 15 weekly sessions. So you're meeting with a patient about once a week for about an hour. And so most of my patients will start off pretty intensive, like once a week, dealing with various skills, looking at how those skills are applied and why they need to be applied based on what the person's going through now, or what they've gone through. Again, 8 to 15 weeks of that weekly intensive phase. And then most people get the gains that they really want to see, or at least have adopted the skills that are going to help them continue to improve in that time. And then we start backing off. We might meet every other week for a couple meetings. And then if things are still good, we back off till about once a month. And some people, I'm like, hey, that's great. They don't really want to see me again because this is a pain in the ass to do. It's all work. Not for me, but for them, because I just sort of tell people what they should do differently. Yeah, a lot of people after that kind of couple of 1 month follow-ups, they're good to go, and they're back off into their life. Some people want to just keep consulting with me because new things come up, or they just want to touch base and sort of do some preventive maintenance sort of work. And so a lot of folks I will just keep meeting with about once a month, just to stay ahead of anything that may come up. So if someone has a little more intensive needs, then we'll meet like every other week. I could get into the more content-based process, and I'll do that really briefly, in case you are familiar with some of these ideas. Nowadays in cognitive behavioral therapy, most people's practice is going to involve dealing with behaviors and cognitions. So thought processes and behavioral patterns that really impact whatever the conditioning is. Again, some anxiety disorder, depression, addiction. So noticing how those behavior patterns and cognitive thought-related patterns show up, trying to identify them in the moment, finding some alternative responses other than the ones that keep getting you in trouble, or keep kind of maintaining some of that depression. Nowadays, probably most evidence-based practitioners go through that process of analyzing these cognitive and behavioral patterns within a bigger context of mindful awareness. So mindfulness is probably the biggest advance in clinical psychology, like ways of practicing mindful awareness, over the past 20 years. And so definitely taken from more Eastern traditions, Hinduism, Buddhism, of paying attention on purpose to the present moment without having such an evaluative, problem-oriented sort of way of looking at things. So a lot of people show up to therapy kind of with this idea that I'm broken and need to be fixed. in the context of trying to feel better and treat yourself better and other people better, the idea of something's broken and needs to be fixed really gets in the way of a lot of the patience and compassion that can really help someone feel a lot better about themselves, other people, and just kind of you think of free throws, right? Trying to sink a free throw. If you're focused on how important it is to sink this shot and all the awful consequences of not making it and how amazing it's going to be if you actually make it, you're going to freak yourself out. And it's really hard to just focus on the process and kind of flow with the process if you're so focused on how important it is to get some outcome. And so much of the improvement in clinical psychology has been a lot of these meditative practices and mindfulness practices that have us letting go of certain outcome focus, focusing more on the process of just keep your elbow in and you know, follow through, make sure you're looking at the back of the rim, and less focus on what happens after that. So what does it really feel like to feel the living breath coming in and out of you? What does it feel like to just feel the buzzing of nerve endings in your fingers? What does it feel like to someone you love died to just be saturated with sadness, with less evaluation of what's wrong with me because I have this sadness, or what's wrong with me because I'm having these panic sensations? The willingness to kind of just be in the moment, practice that mindful awareness, tends to set people up for having a better process through some of those more standard kind of cognitive behavioral interventions that we get into later. So that's sort of the process question. Thank you for asking that, Mr. Yu. Myers-Briggs may help high school and family to assess what career family might be more congenial. Yeah, for some reason they used the Myers-Briggs was based on like Jungian analysis. Carl Jung was one of Sigmund Freud's students, and then some folks made this Myers-Briggs type indicator based on some of Jung's principles of introversion and extroversion, and whether you're more oriented towards intuition versus kind of more data-driven decision making. Regardless of the theory that personality test was based on, it actually does seem to tap some legitimate personality differences. And there is a whole database of types of careers that seem to fit well with these aspects of personality. You could probably do it with any good personality measure. So there are certain personality measures called the NEO that get at like these well-defined aspects of personality, like neuroticism and extroversion and openness to experience, and introversion versus extroversion, and conscientiousness. Those are great. Yeah, there's no need to avoid those. If you're using the Myers-Briggs, it's pretty well supported. And there are people that specialize in career counseling who know the particular scores on the Myers-Briggs that are associated with being inclined towards the legal field or the medical field or the artistic field. And so I think learning about those things is great. In terms of most of these careers, though, you know, there's room for just experimenting, especially when you're young. We tend to live a long time these days, so there's plenty of time to experiment and see what works and see what doesn't work. And even sometimes a step back is ultimately a step forward. You should allow yourself to do that. But yeah, I would trust someone who's saying, that they could administer a Myers-Briggs to you and then show you some of the fields that your particular score or type seems to fit with. Yeah, I would use that data.
All right, since it's close to 4 o'clock, I think we can do our little wrap up. So
Yeah, okay. So thank you so much to Dr. Mascaro. If anyone you know couldn't make it this time, we will be posting an update to our mailing list and Instagram once we have a recording uploaded on YouTube. And we have also posted our last seminar's recording to our YouTube account as well, at CSTEM US. And if you looked in the chat, you will see Dr. Mascaro's emails. And if you have any further questions, because I know a lot of you are very interested in this, you can reach out to him. And he said that he would be happy to respond as well.
And so I
Someone
posted,
asked
go ahead.
if anybody has other questions, email me, but I'll type an answer to this last question. Just so you, for the person who asked it, if they're interested.
And so this concludes our seminar. Again, thank you to Dr. Mascaro. And thank you to everyone for taking time out of your Sunday afternoon to come and listen to our seminar. If you haven't already, please take a few seconds to fill out this survey so that we have some feedback for our future seminars.
It's posted in the chat as well.
All right, thank you so much and have a great afternoon.
Thank you.